Welcome everyone to this session. James and I are very conscious that next is afternoon tea, so that's one piece. The second piece is after this morning we will not be announcing that our claims management is conducted by robots or any sort of artificial intelligence whatsoever. So just to put that on the table. And the third piece I'd like to declare is that I know there are a number of Comcare people in the room today and who will have contributed to what we're about to share with you, our audience. And I'd ask you not to provide a standing ovation at the end of the session. It's quite all right for you just to clap, okay? James and I have a really easy task today because our role is to talk to you a little bit about the journey that Comcare has been on over the last 4 years, and to talk with you about, explain a bit more the results that Jennifer Taylor talked about this morning in her welcome, and to flag some of the direction of where we're going as an organisation and our claims management work. So for those of you who don't know, and most of you will, Comcare has a number of roles. So all of our activity is aimed at supporting participation and productivity through healthy and safe workplaces that minimise the impact of harm. That's our outcome statement. Everything we do gets measured against that. So how much are we doing in those spaces? We've got three main roles under the Safety, Rehabilitation and Compensation Act, and those go to being an insurer, so being the premium setter and the claims manager, being a regulator and scheme manager. So a bit more on each of those. As an insurer, our aim is to deliver sustainable management of the fund. We'll dive into a lot more detail as part of this presentation, but Comcare's been on a journey as an insurer and as an insured scheme for some time now. And the results that we get to share with you today are a result of that journey. As a regulator, most of you will know we're the Work Health and Safety Regulator under the federal legislation, and our role there is to make workplaces safer and healthier. So we do this by promoting continuous improvement in work health and safety and rehab practices and ensuring compliance with our PCBUs. The scheme itself has the lowest injury incidence and frequency rates of any jurisdiction. So we reckon that gives us claim to being the safest scheme in the country. So I'll put that out there, and there'll probably be a question about that at the end. As a scheme manager, we use scheme management to sort of describe all of the other things under the legislation and our role in oversight across the scheme. And so our scheme has a government sector where we're the claims manager and insurer for, but our scheme also has the self-insured licensee arrangements. And so our scheme management functions stretch across the entirety of that. It gives us a unique ability to look at private sector and public sector trends at the same time, and it gives us an opportunity to influence and use better practice from across the different employers and claims managers and parties that we have in our scheme. Our criteria, or our notional premium rate in that space is at 0.86%, which for those of you in the know will know that that's very low. That notional premium rate is a reflection of how affordable the scheme is for a private sector and for public sector entities. And our return to work rate, latest information from the Safe Work Australia survey, sits at 94%, which is really quite a significant result. Additional to these core legislative roles, we recognise there are opportunities to deliver better work health and safety outcomes nationally. So we're a national scheme and we like to take claim to that. We've strengthened our research and innovation capability with a dedicated strategic research and innovation group and a strategy to enhance knowledge of current and emerging trends and address the challenges of the future, which is what this conference is all about. The focus there has seen us establish a unique public-private initiative, the Collaborative Partnership, and there are some sessions today which I would encourage you to get along to understand more about what's happening there. Underpinning our core roles and our focus on strategy and innovation is a drive to collaborate across the schemes and the sectors, to work with employers, employees and other stakeholders to improve health prevention, safety and rehabilitation. The results we highlight today would not be possible without the support and engagement of stakeholders across the scheme. Now, turning to our journey, these are the cool diagrams we get to put up because of the results. So in 2014, the scheme was not in good financial shape. Our funding ratio was only at 68%. There's a bunch of reasons for that, but that'd be a separate presentation. After reaching a fully funded position last year, our scheme remains fully funded, and we don't expect that to change, and that's one of our core objectives in managing the fund sustainably. This was achieved 3 years ahead of target. So when we originally set the target of getting back to fully funded, it was set over a much longer period, but we've managed to achieve that much more quickly. It includes 4 consecutive years of an operating surplus. Sustained favourable claims performance has led to an estimated further reduction in liabilities of around $250 million in 2017-18, and that's on the back of a $393 million reduction in outstanding claims liabilities in 2016-17. The total claims liability reduction has been more than $900 million over the past 4 years, and approximately $1.2 billion has been knocked off the projected liabilities for that same period. That, of course, leads into our premium rate for our insured scheme, so across the public sector. The premium rate for Commonwealth agencies was 1.93% in 14-15. It's now fallen at for 18-19 to 1.06%. And we expect that trend to continue. Comcare recognised back in 2014 that high premiums redirect taxpayer money from frontline services for our agencies. It leaves our clients and Comcare open to criticism. Our key focus of the past few years has been to address this issue, and we've been working with employers in the insured scheme to prevent injuries, streamline the claims process and improve the ongoing management of claims with a focus on recovery at work. I'll now throw to James, who's going to talk to you a bit about the claims initiatives.
Thanks, Aaron. Just to expand a little bit on some of the comparative performance from 14-15 to 17-18, and while we've seen a reduction in claim numbers coming into the scheme, we've also seen a lot more claims exit the scheme. So you can see there a very significant reduction of 3,500 open claims from 14-15 through to 17-18. So that drop in claim numbers and the changes that we've made to our approach have led to significant performance improvement within the scheme. I should also acknowledge here the efforts of our targeted work in the prevention space, and also the increased return to work efforts by the employers within our scheme as well, noting that the sum of the results is the sum of all the stakeholders within the scheme. But as I said, you can see there considerable improvement in the funding ratio, a very significant reduction in premium, which means that Commonwealth employers can spend the money where it should be being spent, and also significant reductions in our claim acceptance rate and that volume of open accepted claims, which has led to $50 million a year less from 14-15 through to 17-18 in terms of claims costs for a financial year. So to talk a little bit about claims management model, the claims management model that we use to operate has had significant change in the past few years, and these commenced in the 14-15 financial year. So in terms of our incapacity or our time off work claims, they're structured into 3 broad segments: our early intervention area, which I'll expand on a little bit later, our emerging tail from 6 to 18 months, and our tail claims, which we regard as more than 18 months. We've pooled our medical-only claims within a specialist area, but within that area we have, we use data analytics and we use review triggers to make sure that there's escalation of risk issues, and so it's a risk-based system. That works in very closely with our clinical panel approach, which again I'll talk a little bit more about, and allows us to make sure that we're directing a lot of our resource investment towards our greatest risk, which is time off work in terms of cost and in terms of liability, but it also means that we have an active approach to managing medical-only claims, and we've achieved some very significant cost reductions in that area. The other key aspect of our change claims management approach, and I think it sort of dovetails in with the other 2 presentations in this session as well, is that the biggest focus has been on more collaboration within the scheme. Collaboration with employers, with employees, with medical and with allied health professionals and rehab providers. I would also note that our claims management model is always one of continuous improvement as well. we are looking at aspects of the model now and looking at ways in which we can enhance the model and some of the learnings that we've noted in the claims pilots, which we'll also cover in today's presentation. So in terms of our focus on early intervention, previously the front end of Comcare claims management had claims managers who just focused solely on the decision of whether a claim's accepted or not. They'd review the information, make that decision. If the claim was accepted, it would be passed on to a different claims manager. Now our early intervention segment has officers that manage claims from the time that we receive the claim 3 to 6 months post the receipt of claim, if the claim be accepted. So this allows them to build rapport with the worker, the employer and the other stakeholders, both through the claim eligibility process and also in that first 6 month or first period of managing the claim. And we know from statistics that the window in which to achieve an effective or the best outcome with a claim is closing quickly, so you have to make every post a winner in that initial stage. To complement this approach, through 2015 and 2016, we've also changed some of our communication strategies. So there's an increased focus on outbound communication with critical stakeholders, employees, employers, and treating practitioners. And we've also revised a lot of our standard letters. So we've moved away from probably the highly technical and legalistic approach that some of our previous communication had to more simple messages that are clear for the worker in terms of what an ongoing entitlement is and what the next steps are in the management of their claim and what they need to do. The focus that we've had on early intervention has also improved results considerably in the time to accept the claim. So if we think of KPIs of 20 calendar days for an injury claim and 60 days for physical or mental disease, at 2014-15 we're at 79% against that KPI, whereas at the 17-18 year we're at 95%. So we've improved considerably in that area. I think as well, in terms of our approach in that early intervention segment, we've also invested very heavily in staff education. So we've been using the motivational interactions training for a number of years at Comcare. All of our new staff go through the training, and the training is not just a one-off course. It also has check-in points so that staff go through the training, acquire some new skills, but there's also check-in points about how they're going with trying those experiences in the workforce and improving and adapting their approach. With regards to effective ongoing claims management, this slide just represents what we think are some of the key areas. So our ongoing claims segment, which is from 6 months post-claim receipt onwards to the closure of the claim, is really, again, we've increased our focus on return to work and recovery. So managing claims to milestones and to goals, and developing individualised plans based on contact with the employee and based on contact with the employer and the treaters. And these plans are centred around reducing or eliminating barriers to recovery at work and return to work, and making sure that we're regularly evaluating progress against those goals and adapting our approach as we go. For those of you, and probably quite a lot here today, who work in the claims management industry, we know that Plan A doesn't always work. If it did, we wouldn't all have to be here. It is claims management, effective claims management. It is about knowing what's going on the claim in real time and adapting to that approach. We've also had a real focus on the adoption of clinically justified treatment within the scheme. So Comcare adopted the clinical framework in 2012, and we use that as a guide to make decisions about what is reasonable and what is appropriate treatment. Our scheme and our approach firmly believes in the provision and not getting in the way of the right treatment at the right time, but asking questions where progress has plateaued or there is no evidence of change or ongoing improvement. We've introduced more targeted approaches within our claims management. So I'll talk about a project around unmet capacity today, but we've also had recently had projects which are focused on soft tissue claims, on mental health claims within the first year, and other targeted cohorts in terms of paramedical or treatment benefits. So to talk a little bit about the clinical framework and our internal clinical panel. So as I said before, we adopted the clinical framework in 2012. It was based on the original document which was developed by the TAC and WorkSafe Victoria. And we found this as a very effective tool in our improved management of treatment benefits within the scheme. We essentially have adopted the framework. We've built reporting infrastructure like treatment plans and review treatment plans around those principles of the clinical framework and those setting of goals. And then we also have a clinical panel approach where we have 11 medical and allied health consultants who do sessional work for us around a range of across a few different professions. So we have physiotherapists, psychologists, pharmacists, medical practitioners and a psychiatrist who do sessional work for us. And their role is around reviewing cases, making contact with treating practitioners and ensuring that the ongoing treatment that someone is being provided is reasonable and appropriate. So as I said, this is an area in which we've made significant gains in terms of our management of treatment costs within the scheme. Treatment costs within the premium scheme have reduced by 25% between 2014-15 and 2017-18. I think to take one benefit, for example, of physiotherapy, in 2012, I think we were spending about $5.5 million on physiotherapy. It was growing at about 10 or 12% every year. At that stage, my hair was brown. With the adoption of the clinical framework and the adoption and the expansion of our clinical panel process, our current expenditure on physiotherapy is reduced from that $5.5 million a year to just over $2 million per year. That's just one example. It's really been an across-the-board reduction as an approach of asking more questions, asking for progress, asking for measurable improvement to be demonstrated, and challenging in the cases where it cannot be justified. And the case example on the slide there sort of talks a little bit more about this approach, where a worker had gone to 120 sessions of physio, then they'd gone to another 400 sessions of hand therapy. This was a case that came through our clinical panel. There was peer contact with the treating practitioner, and what was agreed with the treating practitioner was a graduated reduction of treatment. So six weeks of weekly treatment, reducing down to several months of fortnightly treatment, and then a few more episodic treatments, and then a discharge from therapy. We feel this approach has been very effective for Comcare in its scheme where we have had a tail with a large amount of treatment, where people had received a large amount of treatment. It's not just an arbitrary removal of treatment based on an independent exam. It's a graduated reduction of treatment agreed through a conversation between our consultant practitioner on our clinical panel and the treating practitioner. So we feel it is a much more palatable and appropriate outcome and less likely to be challenged. The clinical framework is something that has been increasingly recognised through AAT decisions in the past few years, and that the AAT is increasingly finding that it's a reasonable framework to help justify treatment. Just to mention quickly about one of our incapacity tail projects, which was about reviewing a cohort of claims within our tail where workers had an unmet capacity to return to work, And what that really refers to is someone who's engaged with him, who's not working in line with the hours of their current certification. So this project reviewed a series of claims within our tail. It was about 150 claims. We found that through working closely with both the worker and with the employer, we were able to significantly progress a number of these cases. Over 40 of them had upgrades in their working hours just through liaison with the employer, and another 20 at least commenced rehabilitation that wasn't previously being commenced on those cases. The net saving as a result of this project was over $23 million in terms of our ongoing liabilities. And what it really did show to us, one, is that you have to have the right triggers and the right data to identify the claims, but also through using a screening process. In this process, we started with about 400 claims, but we used screening tools to evaluate which ones we would invest more time and effort in working with the employer, reduced it down to 160 odd claims and achieved really good outcomes on them. And where you only have a limited resource to invest, having that targeted approach and screening is very effective. And just to quickly mention a couple of other upcoming improvements, I think, within claims management, it will be that continual cohort review to target areas of emerging liability growth. We know that mental health claims in particular are still a significant challenge within the scheme. We are looking at some refinements to our claims management model based on some of the learnings from the claims pilots. We recognise that we think there's more that we can do in the IME space in terms of contract management and options with regard to the engagement and the use of IMEs, and also continually to invest in data analytics. So making sure that we have the right triggers and we're identifying the right claims at the right time. Thank you.
So James has alluded a couple of times to this thing that's been called the claims management pilot. So the pilot, and this does get a little technical, so bear with me because I know that afternoon tea is next. Look, basically how the pilot works and how the arrangement works is that Comcare delegates some of its SRC Act powers to individuals in agencies who are participating. And through the pilot, those two agencies were the Australian Taxation Office and the Department of Human Services. So we delegate some powers to the individuals in those agencies, and they were supported by third-party providers. And so that pilot's been running since February 2016, and it's been administered and worked through and will wrap up now towards the end of 2018, etc. The pilot basically allowed the agencies, the individual in those agencies, to play a greater role in managing the workers' compensation claims from their employees. And that aligned the claims and rehabilitation functions. Importantly, the pilot was rolled out in two agencies who were running a number of other initiatives as well at the same time. They were also run out in agencies where there was strong executive commitment to improving this space and to improving the workers' compensation and rehabilitation outcomes. There's been success through those pilot processes. And so, in a nutshell, new claims dropped, return to work rates improved for those agencies, and there were reductions in current and future liabilities. And so all of the boxes that needed to be ticked were ticked in that space in terms of a pilot process. Other metrics like timeliness, reconsideration rates, affirmation rates and disputes remained aligned with the improvements that we saw more broadly across the scheme. So all of that came together. The results were driven by evidence gathering techniques, collaboration and communication between all the parties involved and bringing those parties together, and regular treatment reviews and shorter timeframes for treatment approval. There are some licensees in the room who are probably sitting there and saying, no doubt that would work. It's been a long-standing truth for us in relation to self-insured licences, that where you bring the employer, the claims manager and rehabilitation closer together, you get better results. And effectively what the pilot has done is to help us see that, but also show us that there are ways for that to be done within the current legislative structure as well. So, following on from the pilot, these arrangements, delegated claims arrangements, because I can't come up with a better name to describe it than that. If anyone has one, please shout out. These arrangements become part of Comcare's claims service offering. So the three options that we'll be going forward with, in all cases, there's a delegation to individuals in the agency, and they can be supported by a third-party provider, by Comcare, or the agency may choose to develop their internal capacity to manage those claims as well. That's something that we've been working on for the last 12 months effectively now, as we've worked through this process, and we're getting close to moving into these new arrangements going forward. So there's a couple of things, this is our last slide, a couple of things for us to sort of wrap up on, and we've just thrown some percentages and stuff up there because that's the conference, workers' compensation conference, and that's what you do, you put up data and stuff. So, and we're sort of showing off. But look, the main piece that we sort of want to leave you with is this for us has been a long process. There are people in the room today, and I can see them, who are ex-Comcare now, but who have had just as much a contribution to this work and to the thinking and the ideas that have come about how we've implemented. It's been a long process, but as you can see, that process and the innovation that we've drawn into our claims space has obviously helped us to achieve significant improvements across particularly the insured scheme, etc. Obviously, there's been no legislative change, which is an important piece. So at one stage, we were presented with a review or a finding that there would have to be legislative change for the scheme, particularly the insured scheme, to see improvements in this space. All of this has been achieved without any legislative change whatsoever. So in terms of the themes for this conference and what we're trying to achieve around that collaboration piece and the innovation piece, we feel that this is a good example of where if people come together, have the right mindset and work together, you can actually achieve big things in this space. Going forward, we don't see the delegated claims arrangements as the only service offering that Comcare can provide. We've made it very, very clear to agencies across the Commonwealth that we're open to more and more collaboration and innovation in that space. And it also presents, I think, with what we heard this morning and what we know is coming through the data around workers' compensation, the future of work, there's lots and lots of opportunities for the private sector part of our scheme and the public sector part to be collaborating on better practices and on those trends into the future as well. Thank you very much.